Hello, everyone, and a very warm welcome to you all. I am absolutely thrilled to have you join me for this explainer on ocular inflammation. Today, we're going to dive into a deeply complex yet profoundly fascinating subject, uveitis. We are going to approach this with the precision a masterclass deserves, making sure that by the time we wrap up, you'll have a rock-solid grasp of this incredible medical mystery. Let's get right into it. Here is our roadmap for today. We'll start by looking at the foundational anatomy of the uvea, figure out how we actually classify uveitis, dive deep into its pathology and complications, explore a few specific syndromes, and finally discuss the essential clinical protocols for managing the condition. All right, part 1, anatomy of the uvea, which we can really think of as the anatomical battleground. Okay, let's get our definitions straight first. Strictly speaking, uveitis is just inflammation isolated to the uveal tissue itself, so the iris, the ciliary body, and the choroid. But you and I know that clinically that is rarely the case. Because these anatomical parts are packed so intimately together inside the globe of the eye, inflammation just doesn't respect those neat boundaries. It almost always spills over into adjacent structures like the retina, the sclera, and the cornea, ultimately involving the uvea as a whole. If you look closely here, notice how this incredibly vascular uveal tract is sandwiched right between the outer sclera and the inner retina. You've got the iris at the front, which leads directly into the ciliary body, and then that extends continuously all the way back into the choroid layer. It is so crucial to keep this interconnected pathway in your mind's eye, because, well, this entire vascular network unfortunately turns into a massive battlefield when inflammation strikes. Moving on to part 2. Classifying uveitis, making sense of all this complexity. To make sense of it all and diagnose accurately, medical professionals have to chunk this complex data. Anatomically, it's pretty logical. Interior uveitis involves the front structures, the iris and the ciliary body. Intermediate uveitis hits that middle zone, specifically the pars plana just behind the ciliary body. Posterior uveitis affects the back of the eye, mainly the choroid. And finally, there's panuveitis, which is exactly what it sounds like, a severe inflammation taking over the entire uveal tract. But we also need to look at the clinical timeline, and the contrast here is absolutely huge. Acute uveitis hits hard and fast. It presents with a sudden, painful, highly symptomatic onset that generally lasts up to 3 months. Chronic uveitis, on the other hand, is a silent danger. It creeps in with an insidious, asymptomatic onset and can persist for many months, sometimes years. Tragically, it's often only diagnosed when the patient finally notices their vision is already defective due to long-term structural damage. Beyond just anatomy and timeline, we have Duke Elder's etiological classification. And honestly, the sheer variety of triggers that can ignite this inflammatory response is staggering. We're talking infective causes like bacteria, viruses, or fungi. It can be allergic, where the body's own immune system just overreacts. It can be triggered by toxins, physical trauma to the eye, or even broad, non-infective systemic diseases like arthritis. And, quite humbly for modern medicine, a massive portion remains idiopathic. We simply do not know the cause. Section 3. Pathology and complications, or as I like to think of it, the exaggerated inflammatory response. So why exactly is uveitis so terribly destructive? Well, the fundamental answer lies in the physical makeup of the tissue itself. The uvea is extremely vascular, and structurally it's quite loose. When you irritate a tissue like that, it triggers a massively exaggerated inflammatory response. It swells rapidly with exudate and inflammatory cells and literally turns the delicate inside of the eye into a severe and damaging war zone. Under Wood's classification, we separate these pathological responses. Non-granulomatous pathology is usually an allergic or toxic thing. If you look under a microscope, you'll see plasma cells and lymphocytes, but crucially, no nodules. Granulomatous pathology, on the other hand, is almost always a proliferative response to a direct organismal invasion. Think tuberculosis or leprosy. Here, the body physically walls off the foreign invader, forming these actual nodular aggregates made of epithelioid and giant cells. Now here is why this matters clinically. If we don't manage this quickly and properly, these exaggerated processes lead straight to irreversible structural damage. We're talking complicated cataracts forming right over the lens. Inflammatory debris can clog up the eye's drainage system, causing secondary glaucoma. The inflamed iris can physically stick to the lens, creating posterior synechia. And the absolute worst-case scenarios, retinal detachment, or if this is bulby, which is the tragic, irreversible shrinkage and death of the entire eyeball. Just to bring this abstract pathology into a terrifying clinical reality, take a look at the irregular, festooned pupil in this patient suffering from iridocyclitis. You see that irregularity? That is caused by severe posterior synechia. The inflamed iris is literally glued down to the structures behind it. And right there in the center, you can clearly see the white opacity of a complicated cataract. This is exactly what untreated inflammation does to the human eye.
Let's move to part 4, specific uveitis syndromes and identifying unique clinical markers.
Because uveitis is tied to so many systemic conditions, picking up on unique clinical clues is like being a medical detective. For instance, in lepromatous uveitis, we look for distinct, glistening iris pearls forming a sort of necklace near the pupil. In sarcoidosis, you expect non-caseating granulomas and raised ACE levels in the blood. Fuchs uveitis is a really fascinating one. It presents with iris heterochromia, so the eye color actually changes, but notably there is an absolute absence of those sticky senecae we just talked about. And then there's phacoanaphylactic uveitis, which is a massive, severe reaction triggered simply because the eye's own lens proteins accidentally leaked out of their capsule. Of course, modern medicine also allows us to use genetic markers as an incredible roadmap. Take patients with the HLA-B27 gene. They have a massive association with ankylosing spondylitis, typically presenting with acute, recurrent, non-granulomatous attacks. Contrast that with the HLA-B51 marker, which is strongly linked to Beggett's disease. That presents as recurrent uveitis with pus in the anterior chamber, alongside severe oral and genital ulcers. You see, the eye really is a direct window into the overall systemic health of the patient. Finally, part 5, managing the condition and restoring peace to the uvea. So having understood the pathology, how do we actually restore peace to the eye? Well, we follow a very clear 3-step clinical protocol. Step 1, non-specific therapy. You have to put out the raging fire first, regardless of what started it. Step 2, specific treatment. Once that fire is controlled, you hunt the underlying enemy. And step 3, treating the complications. You have to repair the structural damage left behind by the battle. To put out that initial fire, we have some very powerful pharmacological tools at our disposal. Cycloplegics, like atropine drops, are absolute lifesavers. They paralyze the ciliary muscle to stop excruciating spasms, and they mechanically dilate the pupil so the iris simply cannot stick to the lens. Simultaneously, we bring in corticosteroids, the absolute mainstay of treatment, to forcibly suppress the immune response. We might use broad-spectrum antibiotics as a protective umbrella, and employs simple physical measures like hot fomentation and dark goggles that really gives the patient some comfort from the severe photophobia. But here is the critical catch. Steroids only mask the symptoms. They do not cure the underlying disease. If you just stop the steroids without fixing the root cause, that fire is going to reignite immediately. Therefore, specific therapy is absolutely essential to prevent a relapse. If your clinical sleuthing uncovers tuberculosis, you must administer a full course of anti-tubercular drugs. If it is leprosy, you treat systemically with dopsone. You have to eradicate the infectious invader completely. And yet, despite all of our clinical protocols, our genetic mapping, and our advanced pharmacology, a very humbling reality remains. Over 25% of uveitis cases are still classified as idiopathic. We literally have no idea what causes them. It really leaves us with something profound to ponder, doesn't it? What intricate, complex secrets does the human immune system still hide from our understanding? Thank you so much for joining me on this explainer today. Keep questioning, keep learning, and keep exploring.
Like, share,
Comment, subscribe. Oh, and hey, don't forget to click that bell icon for notifications.